What is up, guys? We are back again with another episode, and thankfully, Gary is not with us. He's off on a holiday. He's supposedly, he says, "Oh, I've never taken a holiday in my working years." I've seen him on holiday. That's baloney, right? He's been on holiday. He's checked out mentally. He's not working, but he says at least this 2-week holiday that he's on he's checked out. He's not doing any work at all apart from the bare minimum that we occasionally have to do when you run a business. But anyway, look, we're not here to hear about Gary's life. We're here to talk we're here to continue the female health series, and in this episode we're going to see how far we get with it, and we're going to start the topic of menopause because there's a lot to cover in it, right? And as I've said before, look, I am an idiot, so we're not going to listen to me on the topic. We're going to listen to someone that actually knows what they're talking about, or at least I hope you know what you're talking about, Nicola.
We'll find out.
So menopause, what's the story here? Because we've been talking about, again, a lot of different female health topics. We've been talking about the menstrual cycle in general. We talked a bit about, menstrual cycle dysfunctions and, different things that can occur. But we mentioned that this stuff does come to an end, right? The menstrual cycle comes to an end. And that's not necessarily intuitive, right? That's not something that you would be like, oh yeah, that's just something that happens, Like if you were just to think, oh, here's I don't know, you're literally in the wild or something, you're like a zoologist, you're an alien that comes down and you're fucking just looking at animals and going, oh yeah, this is something that occurs. You wouldn't intuitively think, oh, it makes sense evolutionarily to have a cessation or an end to the ability to reproduce. If you're just thinking about it logically, you go, surely you would want to be able to just continue reproducing for the entire life of the organism, right? So it's not intuitive, but it is something that we have to deal with. It is something that most women, as long as you live long enough, most women are going to deal with. So what is menopause? What's the story here?
So basically, to put it, bluntly, is menopause is a cessation of a woman's natural menstrual cycle, and it occurs kind of in women's kind of 40s, 50s. The average age is around 51, particularly in the Western world. There's a couple of main phases of menopause which I think are important to go through. It's important. It's a word that's kind of thrown out kind of a lot in the media, and you hear a lot about the perimenopause, but oftentimes we don't actually know. A lot of definitions are thrown around. We don't actually know kind of what they mean. It's one of probably the most under talked about topics of women's health. And even though there's a lot being put forward about women's health in kind of the last couple of years, it's still something that's only menopause and perimenopause, something that's really only kind of catching ground now. So we know, a lot of the recommendations for women's health are on the presumption of someone kind of with a menstrual cycle. So we need to kind of turn the focus now more to perimenopausal women and postmenopausal women, because there are some kind of distinct recommendations that we can make for them, not only in terms of kind of symptom control, but also quality of life, and just kind of better health for that kind of older age as well.
Yeah, it's really important as well, because especially like when I grew up in the 90s, back in the day, you didn't have great information for women training, nutrition in general, right? And I feel like that's just kind of turning a corner, but it's kind of just treating it as if women are a block. It's just one continuous. There's no different life stages. There's no different things that occur across the lifespan, but there clearly is, right? So we need to, again, refine the message, refine the population that we're talking to. Who are we talking to? We're talking to someone that is perimenopause. We're talking to someone that's menopause. We're talking to someone that's 25 years old. We have to be very specific with that stuff. And mass media generally doesn't favor specific messages. It's all let's hit the biggest, broadest target audience that we possibly can here, which is just a generalized messaging. So like you said, there are some things that we have to pick. Can't even speak. There are some things that we have to pay attention to and to take account of when we're talking about menopause. So what are we talking about with that?
So I think a good place to start, like I said, is kind of going into some definitions. So the first one, perimenopause. Again, you know, an old client of mine, I remember, you know, a lady in her early 40s, you know, really like successful, intelligent woman. She turned to me one day, she's like, what the hell is a perimenopause? She was like, I'm hearing all these things. It's all in the media. Apparently I'm perimenopausal. She's like, what's going on? She's like, is this all a gimmick? But it just kind of goes to show that, you know, I suppose someone in their early 40s is only kind of hearing these terms now, you know, kind of it isn't a good sign. It's more of a reflection on our education rather than anything else. So I suppose that this is a good point to start. So perimenopause is essentially kind of the lead up, or it's kind of the transition into menopause itself. So perimenopause, what you'll see is these are kind of a fluctuation in hormones. So usually kind of for the normal menstrual cycle, you see an even rise in hormones kind of throughout the month. But in this kind of perimenopausal phase, our hormones become a little bit more dramatic. You see kind of greater dips, and you see kind of higher peaks throughout the month, and you will have more kind of anovulatory cycles. So that's where kind of the follicles in the ovaries might not develop. And so you'll have kind of more of those. The ovaries themselves kind of begin to decrease in size, and you'll have a lot of kind of associated kind of vasomotor symptoms, which are kind of the hallmark of perimenopause. That's where you hear about your kind of your night sweats or your hot flushes, that sort of thing. So, you know, that can, you know, kind of happen, you know, in a woman's 40s, and then leads right up to menopause. So menopause is actually just kind of one point in time, okay, instead of this kind of long, broad thing that we associate it with. It's kind of the anchor point, and it's defined at 12 months after the kind of final menstrual period. So it's kind of one point in time. Average age, like I said, is about 51 years in the Western world. And the best way to know, you know, when you think that you will be going through it is actually asking your mom, because there's a strong genetic component as well, and also associated symptoms as well. It's good to ask your mom how she went through her menopause. And then after that point in time, then it's post-menopause. You know, for simplicity's sake, we'll probably just be referring to kind of menopause here kind of throughout the podcast, but after that point, you're kind of post-menopausal. And why it's so important as well to kind of be putting this into media and putting this forward is we are living longer. And that means we are in this post-menopausal state for what used to be kind of, you know, almost like a third of our lives. It's nearly becoming probably about half of our lives now at this stage. So it's really important, again, to kind of know what are the associated, you know, kind of health issues that kind of crop up in that postmenopausal phase, and what we can do now to kind of lessen those risks.
100%. I always think of the like perimenopause. Again, I'm an idiot, so look, take this with a grain of salt. But like I always view it, you know, like an analogy or a metaphor. I'm like, right, ideally, you know, if we have a physiological process, we want some sort of like dimmer switch. We don't want like, oh, it's just going to turn off, you know. A lot of people think of menopause as if it is just a switch, you know, you just flick the switch, right? Now, in my estimation, at least, the perimenopause to menopause, it's not like that dimmer switch. It's more like if you had a light that, you know, you flick the switch and it's just on the edge of being broken. Sometimes it goes really bright and sometimes it just completely stops and it's flickering on and off. That's how I kind of think of it. It's this perimenopausal stage. It's like the flickering, it's up and down, it's back and forth, and you're kind of like, I don't, like, if I flick this switch here, I don't know if this light is going to be functioning. I don't know if it's going to be on. It could be off today, it could be flickering today, you don't know. So it's a very tumultuous time, I suppose you'd say. Like it's up and down, which obviously, and we've talked about it before when we talked about the menstrual cycle in general, it's usually we want to look at the magnitude or the amount of hormones, but we also want to look at them relative to the other hormones in the cycle as well. So we've got a stage where we could have higher or lower amounts of certain hormones, but then we also have a position where we could have a change in the relative proportion of hormones, you know, which makes for some interesting symptoms, shall we say. But that's also just one aspect of it in terms of, okay, we've got this perimenopause and, you know, we'll call it the postmenopause period. But that's not the only reason we could have menopause. You know, there are other reasons, like, you know, maybe we'll talk about them here now, because you will see this as well, even though obviously it's not as frequent as just the normal progression that most people go through. But you could have menopause in your 20s, for example, surgery, whatever, you know. So are there any other like causes of menopause? Because that's just the natural, the normal, you know, but what else could happen?
Yeah, absolutely. So, like you said, there can be, that's what we were describing there was, you know, like a naturally occurring menopause, that kind of flatlining of hormones in that postmenopausal phase stage of life. But then you can also have, you know, an induced menopause. So that might be, like you said, from surgery. So when particularly, so a lot of women might kind of have hysterectomies that may or may not include kind of the removal of the ovaries as well. So removal of the ovaries will kind of send you into that kind of an induced menopause. And as well, women who have hysterectomies as well, but the ovaries are still intact, and they will hit menopause on average a couple of years earlier as well. Then someone else might be on chemotherapy or might have had kind of pelvic radiation that might put them into an induced menopause. So with those, there's no kind of perimenopausal transition, like it's, you know, kind of a surgical thing, or, you know, like I said with the chemo, it's more of an iatrogenic, you know, effect. So we don't see that kind of those kind of vasomotor symptoms kind of with that we would kind of with the perimenopausal kind of transition. It kind of happens more kind of suddenly, I suppose.
That's the flick the switch.
Yeah, exactly. It's more of a flick, like you were saying. So it's associated with more, obviously, in you know, an early loss of fertility, and then there's a greater risk of kind of cardiovascular disease and osteoporosis. So with these women, they will because that might happen kind of at a younger age, they might be offered kind of hormonal therapy kind of, you know, earlier on. Well, they should at least, but we'll talk about that a little bit later on. And then other women then might have an earlier kind of menopause kind of because of primary ovarian insufficiency. So this typically occurs in women kind of under the age of 40, and it might be something that's transient, it might be something that's permanent, and it can be associated with kind of many health conditions, whether that's kind of autoimmune, kind of thyroid issues, or genetic abnormality as well.
And we also have to like factor in on this, like we talked about before about red S, you know, or like the female athlete triad or whatever you want to call it, you know, like you can have amenorrhea, okay? And like we're saying here, oh, menopause is like, you know, it's basically you haven't had a menstrual cycle for a year, and we're kind of using that as our like cutoff. But you could have been amenorrheic for a year, you know, and are we like, oh, are you in menopause then? Like you could be in your 20s. And this is where, again, the definitions are a little bit like, it's hard to be very precise with this stuff. But people often forget, and this is the reason I brought it up, is like you could be, say, an athlete, or you could be someone that's really like gunning with your training. You really like training. You're really pushing hard. Maybe you started dieting. You want to lose a few pounds for the summer or whatever. Like you could be in your late 30s, your 40s, and become amenorrheic from the exercise. And then you can start thinking like, oh, maybe it's menopause. Maybe that's the thing, you know, that's just, that's what happens, you know? And it's a really weird situation that you have then, because, well, at least I think it would be where you're like, all right, actually, I think I went through the menopause, and then all of a sudden you started having your menstrual cycle again because you started eating more, sleeping more, doing less training or whatever. So it's not like this is just like, all right, we have the exact, like, I'm sure there are ways to do it. Like, I don't know, you measure ovarian reserve or whatever. But it's not like we have an exact, this is exactly what happens with menopause that distinguishes it from any other reason that you would have, no menstrual cycle anymore, you know?
Yeah, absolutely. I suppose that's where it's important where that kind of definition with the primary ovarian insufficiency comes in, where it's kind of under the age of 40. But menopause itself is kind of more of a clinical diagnosis, I suppose, based on symptoms, based on, like we said, kind of cessation of the kind of last menstrual period. Kind of blood tests and that kind of thing aren't really necessary, but in that younger age they are, because like we said, it can either kind of be transient or permanent. So we need to rule out whether there's, it's amenorrhea, like hypothalamic amenorrhea, whether it's like a thyroid issue, or whether there's something else that's actually stopping this rather than kind of the ovaries themselves, and it's then that maybe kind of blood tests might be more indicated.
Yeah, and like there are so many causes, like literally like cancer or different things, like so many things that could happen that could disrupt your regular menstrual cycle. And if you just go, oh yeah, that must be just menopause, like it's somewhat helpful to be like, okay, obviously look, again, you want to go like Occam's razor, like what's the most likely thing here? If you're 45 and you're like, okay, I'm having maybe some symptoms of perimenopause, and I'm, like amenorrheic, we'll say, don't have a period, you could be like, okay, maybe it is menopause, But if you're whatever 25 and you're like, yeah, I haven't had a period in like 2 years, I wouldn't necessarily be going, oh yeah, it's definitely menopause.
Exactly. So yeah, under the age of 40 in particular, and even after that, we really need to rule out a whole host of other things before we think about that. But it's also important to note, even if you're kind of not nearly at that stage now, but you are someone who's kind of, lost their period for a year, kind of the health concerns that we'll be going through, they're irrelevant for someone who's been amenorrheic for a year, but if it's hypothalamic amenorrhea, and coming back to red S, etc. Those concerns hold true kind of no matter the age.
Exactly. So look, there's a lot of causes. But let's just say, okay, we've got this, there is a clear distinction between a natural menopause, in your 40s, 50s, whatever, or it could be 30s, again, whatever, different places around the world, whatever. We've got this natural one. We've got this, like, we'll call it again, an induced menopause, and then we've got this like primary ovarian insufficiency. And then we also have these, we'll call them tag-alongs, where it's like, it's not actually menopause, and you could actually get it in your 40s and make you think that you've gone through menopause, but it's not. There are also, and I'm talking about like red S and that kind of stuff there, and then there's also potential like disease states that could cause, well, they could also cause menopause. Like you could have something that occurs that then induces menopause, but there could also be something, an illness, disease, whatever, that causes you to be amenorrheic. So there's a lot of stuff going on here, but let's just go through the rest of the episode as if we have a nice, like, clear definition of this is menopause. This is, when people think of menopause, that's what we're talking about here, So we have some of the causes there, right? What else? Like, how do you know? Like, what are, like, let's call them symptoms. What's occurring here? What's someone gonna feel? Because that's obviously what people actually care about. They don't care. It's like, okay, cool, I've gone through menopause. Like, who cares? I thought maybe if they want to have kids, they're like, okay, I still care. But they're like, all right, who cares? But they clearly do care because they're experiencing some symptoms here. They're experiencing some issues. So let's talk about the symptoms, and then let's talk about the health issues, I suppose, that we also have to consider. So what are the symptoms here?
Yeah, absolutely. So like I was saying, kind of one of the big things, one of the hallmarks of perimenopause in particular is those kind of vasomotor symptoms, which, what we kind of refer to like hot flashes and kind of night sweats. So it's kind of, hot flashes, whatever you want to call them, are those kind of periods where the kind of transient kind of, flushing, perspiring, almost like a burning sensation over the body, over the face. And then the body temperature generally, turns back to normal, and then a chill will often follow that as well, and maybe kind of a bout of kind of anxiety too. A lot of women can get night sweats as well, which kind of has a knock on then of, disturbed sleep. A lot of women might have, I suppose what I should say first of all as well, a lot of the symptoms sound awful. They sound, and if you were to Google them, you're like, Jesus, does every woman go through this? And like, realistically, kind of a lot of women, about 25%, will have very mild symptoms, 50% will have some symptoms, and another 25% will have kind of really debilitating symptoms. But hot flushes are kind of the main one, and then kind of 85% of women kind of will kind of experience that, particularly in that kind of perimenopausal period, and it should kind of decrease in severity and hopefully stop or definitely lessen in that postmenopausal period. But you can definitely think of that as the big one. That is the night sweats, like we said, that has a knock-on effect of sleep disturbance. Mood disturbance can be another thing. Again, that can be multifactorial. It's a huge life change. You're also having these symptoms, like you're saying, the hot flushes. If your sleep is disturbed, I mean, that has a knock-on of mood disturbance as well. And then you kind of have the genitourinary symptoms as well. So there can be vaginal dryness, there can be painful sex, etc. Another one then, obviously in the kind of health and fitness industry, we're looking at kind of, an increased kind of BMI, increased fat mass, particularly kind of around the midsection, which has its own kind of knock-on of being associated with an increased risk of cardiovascular disease. We're looking at thinning of kind of the hair, thinning of the bones as well. So osteoporosis, again, is a huge issue. So 1 in 2 women in Ireland will suffer a fracture that's related to osteoporosis. So again, another kind of, big thing to consider for during this time.
And a lot of the stuff, this is why we're doing this episode, a lot of the stuff you can, we'll call it combat, relatively easily. For example, again, the osteoporosis, like we can do resistance training, we can help with that. Yeah. Is it going to be perfect? No, some people are still going to be at risk. We just have effectively, we'll say, no estrogen, no beneficial effects of estrogen here. So some people are just going to be at risk. However, you can delay or mitigate that risk as much as possible. So some of the symptoms, some of the things that occur, health issues around that, we can look at, and we'll talk about them a little bit more in a second. But like you said, this just sounds like a fucking shit time.
Yeah. Yeah, absolutely. Like it sounds terrible, and that's why a lot of women, particularly if you Googled it, you're like, Jesus Christ, and it can be a huge cause of anxiety for a lot of women, and even women in their 30s. If they get really warm on some day, you'll be like, Jesus, am I going through the menopause? Is this what a hot flash is? But the thing is that like I said, a lot of women will have mild symptoms, and like I said, there's about 25% who have debilitating symptoms. Now that's 1 in 4. That's still pretty significant, but we do have a lot of therapies that now to combat those symptoms, and particularly kind of menopausal hormonal therapy is something that's kind of being brought kind of to the forefront now, and we know that it works, and we know that it is that a lot of the benefits of it kind of weigh out the risks, whereas previously there was a lot of taboo around the subject. But we do know that it works and that it helps a lot of women. I know we'll talk about that in a little bit more detail later, but it's just a good thing to point now that we do have a lot of interventions that are really helpful, and kind of our kind of main gig, I suppose, is nutrition and training. So, and that really kind of goes hand in hand with the medical kind of therapy.
Yeah, it's a weird one because a lot of people are hesitant to even look at the medical routes. They're like, oh, like this is a quote unquote natural thing, I should just let it happen. But, and we'll talk about it in a second, there are health issues that are associated with this, because you're basically moving. It's actually really weird in terms of if you look at the hormones, like menopause, like if you look at all the symptoms of menopause, right? And then you look at all the symptoms of someone using a drug like trenbolone, right? You see like bodybuilders, they use like trenbolone, right? And I'm fairly certain trenbolone is a synthetic progestin, I think anyway. But people will say stuff like, oh, I take Tren, I take this steroid, people do it in the bodybuilding world. They're like, oh, to get bigger, to get stronger, or whatever. And they will describe all of the symptoms of menopause, So it's like people are putting themselves through this, intentionally. So it's a weird one in terms of we have huge populations, even in men, that have the same symptoms because they're using this drug, right? So that's a little bit of a weird side tangent, but people are very hesitant to actually treat this stuff with drugs. Like if you have heart disease, you go to your doctor, you go, oh, I have heart disease. People are a little bit hesitant sometimes to take statins, for example, but if you go to your doctor and you're like, oh, I have hot flashes, I think I'm perimenopause, and I'm like, oh, my hair is really thinning, whatever the symptoms are for you as an individual, because obviously, not everyone gets all the symptom list, right? And if your doctor said to you, oh yeah, okay, well, we can put you on hormones, now it is usually a lifelong therapy, so it is something that you should consider, strongly. But people are hesitant to that. People are like, oh, like, hormones, I don't know. And there's plenty good reason for that. And we'll talk about that either in this episode or in a future episode around like hormone replacement therapy for women. But it is a strange one that people are just very hesitant to do that, especially as we know, it's not like you can still make these hormones yourself. It's not it's not like this is a process that you can just keep going with. It's like, no, we know you've basically reached the end of the line with your ability to produce these hormones. So you either have to accept that you can't get these hormones anymore, or not in sufficient quantities for whatever, or you just have to accept, that, or you have to effectively supplement with that.
Yeah, absolutely. You'll hear a lot of women, they'll say, I'm not a pill popper, and that can be, probably maybe the only reason why they won't go on the therapy, even though a lot of it is a patch. But they'll be like, I'm not a pill popper, I don't want to do that. They think it's something that they need to toughen out. And as well, again, some of the early research was showing kind of huge negative effect on women. But again, they were using the wrong type of kind of, like progestins. It was also in women kind of that were, 10 years post-menopausal. So a lot of the research that has been done in kind of the appropriate group, kind of with the appropriate hormone replacement or hormone therapy, I should say, has shown great benefit to a lot of women.
And I don't know what the process is here, but obviously, like, you're a doctor in the Irish medical system. At least I know we have a lot of worldwide, I should say, people that listen to this. But what would it be like if you are interacting with the Irish medical system, for example? You're just like, right, I'm perimenopause. I've done my own research. I've listened to the Triage Method podcast, and I'm thinking I'm maybe considering, some sort of pharmacological intervention here. What would be the process if you went to your GP and you're like, right, I'm having these symptoms? Would that be something that they would discuss? Would it be something that they're just like, fuck off? What's the process?
No, absolutely no. Your GP will be your first port of call, and then after that, you can be referred to a specialist if necessary. But most GPs will be qualified in discussing that with you. And again, the treatment will depend on kind of what your symptoms are. So whether the hot flushes is your main issue, whether it's kind of, like I said, vaginal dryness is your main issue, whether continence is your issue, they'll be able to kind of assess your history, and then kind of refer if necessary. But your GP is definitely the first port of call.
Fantastic. And we will talk about hormone stuff in a future episode. I just wanted to, for my own knowledge at least, So look, we've talked about a lot of the symptoms. Obviously, look, we could go do a deep dive with some of these symptoms because, again, they sound fucking awful, like night sweats and just hot flashes and fucking everything else. But anyway, look, there are health issues as well, and we touched on some of them a few times, but it is important to, again, just reiterate that there are potentially significant health issues if we don't do something at least, or don't keep this in mind. And I know obviously this is like a health and fitness podcast where a lot of our listeners go to the gym, they're into their training, they're into their nutrition, whatever, and a lot of people focus on the physique changes. For example, they're like, oh, look, you basically move from more of this like female body fat distribution, you move more towards like a male body fat distribution. Like men will generally what's called an android body fat distribution. Men will generally like gain fat on like their stomach, their belly. That's where they gain the majority of their fat, and like it's just where they put it on. Like you see guys and they literally have like shredded arms, shredded legs, like literally you can see veins, muscles, everything, but they have like a gut, like you see that all the time, right? Whereas in women, oftentimes you'll see like, okay, you could have like a completely lean upper body, but the majority of your fat is just stored on your like bum, your hips, your legs, and that's actually a more healthful, we've talked about it before, that's a more healthful body fat distribution. Whereas the male body fat distribution, having it all in your visceral space there, around your organs, around your abdomen, on your abdomen, like that's less health promoting. And again, in the current way we look at like aesthetics, we're like, oh, I want to have that six pack, everyone wants to have the six pack, so we very much don't like that, we're like, oh, we don't want to have that, even though look, it's just a natural body fat distribution, but it is associated with health issues as well, you know. And this is generally why we see a lot of the health issues that men get earlier in life, for example, like heart disease, like after menopause, you start seeing this real uptick in women. And unfortunately, especially with heart disease, and again, we've talked about this before, like heart disease in women is already underdiagnosed. It's already something that is just kind of like people aren't aware of the symptoms, both like medical practitioners and just the average individual on the street. They aren't aware of the symptoms in women. They're just like, oh, like these are symptoms in men, or this is something that men have to think about. It is like heart disease in general is something that everyone has to think about, but especially as you come to this perimenopause, menopause like transition, and then afterwards, it is something that we have to consider a lot more as a woman, right? But what are the health issues? What are we thinking about here? What's the story?
Yeah, so there are three kind of, main, issues, and that's kind of cardiovascular disease, osteoporosis, and then pelvic floor dysfunction. So estrogen is cardioprotective. It's also protective of your bones. And that kind of post-menopausal period, you have kind of a flat line of your hormones, particularly estrogen. So we kind of lose that kind of protective function that it has, on the heart and on the bones. So you'll see kind of the cardiovascular disease is the highest cause of mortality in women in that age. You'll see, like you said, that kind of redistribution in fat, and then osteoporosis as well. Particularly, I'm just after coming off my orthopedic rotation, which is just looking after all the little old ladies with hip fractures, and kind of the mortality and the morbidity that's associated with that. Like I said, kind of 1 in 2 women in Ireland will have a fracture related to osteoporosis. And the thing is that statistic, that doesn't have to be inevitable. Again, that's due to, I suppose people being kind of, frailer, kind of in that kind of younger kind of perimenopausal period, people who have kind of no experience with kind of strength training, that have kind of low vitamin D levels, that have kind of a poor diet. So that kind of statistic doesn't have to be kind of as high as it is. And particularly when you see it in hospital, and you see someone that's come in, particularly with what we call like a neck of the femur fracture, kind of the mortality that's associated with that. And even just someone not returning to their kind of baseline function, kind of an elderly lady that was kind of flying about at home, comes in with a hip fracture, and now, needs to get the whole house adjusted because she won't be able to kind of get up the stairs. It's kind of, it's your independence, and it's something that we don't kind of value when we're younger, but then we are living so much longer that it is something that kind of needs to be put to the forefront. And it's definitely changed the way even
I think a lot of people are way more aware of it now post COVID, because like imagine you are an older person and like you again get a fracture, you lose your independence, you're basically confined to your house then. And a lot of people experience that over COVID. Like it's fucking mind numbing, if you're just like, I can only go, especially if you have a smaller house or like an apartment, like I live in an apartment, like, very mind numbing if you just, that's all you're able to do. So it's not just we'll call it like the hard health outcomes in terms of like, if you say the osteoporosis or whatever, it's all mental health aspects.
Yeah, well, this is the thing. I mean, and this is, what's happening is, people are coming in, they have a hip fracture, they can't return to their baseline kind of function, so they need to leave with either a Zimmer frame or a stick, but then they live in a 2-story house, so then they can't go home because the house would need to be modified. But again, that's a whole kind of issue with the health system. So maybe they have to go to a step down hospital and they pick up either a bed sore, or they pick up, COVID. I mean, the amount of our patients, waiting rehab that, just picked up COVID along the way is insane, or another kind of hospital acquired pneumonia. So it's just, I know I'm painting a pretty like grim picture, but it is just like there's a lot to kind of take into account with this than just kind of like go to the gym, So yeah, so those, so particularly kind of, heart, bones is a big one that I'm drilling home, particularly because I've just come off my orthopedic rotation, but then pelvic floor dysfunction as well. So, you're looking at kind of particularly like urinary stress incontinence. So that's kind of when you, kind of laugh, cough, sneeze, that you will experience kind of issues with kind of bowel or bladder incontinence. And then prolapse then is the other issue. So over kind of 50% of women will experience symptoms of prolapse. It's kind of a scary word, but again, that 50%, it doesn't mean kind of a severe prolapse. Prolapse is essentially when the vaginal wall isn't kind of strong enough to kind of hold in all the organs that are in the pelvis. So like I said, kind of bowel, bladder, etc. So you might kind of feel a little bit, kind of fall out, I suppose, for want of a better word. And that kind of happens as well because of the withdrawal of estrogen. The vagina has a lot of estrogen receptors. So in that kind of post-menopausal period, it's not, you won't necessarily be having these symptoms only if you've had a child. So you will just kind of experience with that withdrawal in estrogen as well.
Yeah, like we often forget that like hormones do things in our body,
Yeah,
and
exactly.
It's not just like the extra stuff. It's not just like, oh, testosterone helps with building muscle. It's not like just that. It's like, no, you need these hormones for baseline functioning. Like this is for the actual ability of your body to do the baseline.
Exactly. Yeah. So that's why we need to either kind of treat that kind of, kind of with our kind of lifestyle or nutritional interventions. And then, like I said, there is a role kind of for medical therapy kind of in terms of symptoms, whether that's, medication, whether that's like topical estrogen. Again, it just depends on what kind of symptoms that you're experiencing.
Yeah. And the way I generally at least think of this is we want to go into this period of our lives with an excess. We want to go in with an excess of muscle. We want to go in with an excess of bone to lose. We want to go in basically well prepared.
Yeah.
To have stuff to lose. Like that's what we ideally want. We want to be in a position where, like, if you do lose some bone, like we're going to have to. There is some trade-off. Like there is a trade-off here. You're just going to, as we get older, you're going to lose some muscle. You're going to lose some bone mass, unless obviously you take up, I don't know, resistance training or something in your older age and you never did it before. Like maybe then you're going to gain. But either way, the vast majority of people are going to lose some, right? So we want to have that prepared. We also want to have an excess of strength. We want to be very strong in all of our muscle groups, but also obviously some of the more specific muscle groups that we might be thinking about. Okay, well, I don't know, say your legs, for example, and your lower body in general. You want that to be strong because that's going to help prevent fractures in future just by weight bearing exercises, but also so you can catch yourself, so you can, you're more resilient, more robust to issues, but anyway, look, unless you have anything else to cover in terms of the really beautiful, nice picture that we've painted here of the perimenopause and menopausal period. If there's anything else, now is your time. To otherwise, let's move on to training. We might not even get all the training covered today. We will definitely be doing future episodes. But where, again, unless you have anything else to cover, where do we start with this stuff? Like on the training side, at least.
Yeah. So with training, like you were saying, this is something that you want to be doing kind of during the perimenopause, like at least kind of like minimum is kind of building up your kind of resistance training, is building up your bone health. Now, that's not to say if you're hitting that kind of postmenopausal period that you're like, okay, well, I've missed the boat. There's still a role for exercise there. Absolutely. But definitely you want to be building enough kind of muscle mass and kind of bone strength in that perimenopausal period. So like we said, estrogen has a protective effect on our bones. And then it also provides us with kind of an anabolic stimulus kind of for muscle growth or muscle protein synthesis. So we kind of lose that in as we go on. So that's why you kind of want to, build enough tissue during this time. So you want to be active during your younger years, and then going into perimenopause, kind of building up kind of impact and strength work. So having kind of a mixture of kind of plyometric training and then also kind of resistance training, kind of loading your joints. Endurance training generally kind of doesn't work as well, and there doesn't need to be as much of an emphasis on it. You still want to be doing some cardiovascular training, but definitely endurance can kind of take a little bit more of a back seat, unless that's kind of your gig,
And even if it is, like, obviously, if you're like, I really love running, it's what I've been doing my whole life, like there is obviously a role to play there, or there is effects there in terms of bone building. It's just not as effective as other things. It's also not as effective at like building muscle. But again, if it is, like you said, it is your gig, if that's what you like to do, we're not saying stop that. But endurance training does have less of a a benefit in terms of the muscle building, in terms of the, you know, bone building. But we also have to consider that it does have cardiovascular benefits, and cardiovascular disease risk is something to consider. So we're not anti-cardio by any means, but if we do have someone that's coming to us and they're like, look, I'm, you know, perimenopause here, I really need to be thinking about the next few years, we're probably going to focus a lot of our time and our attention on resistance training, so that we have a reserve of muscle, reserve of bone mass, and a reserve of strength. You know, at least that's what I would be focusing on.
Definitely. So like we said, having a mixture of even kind of low impact plyometric training, you know, strength training. And again, it kind of, you know, depends where you are, you know, kind of with that training, but slowly trying to kind of build up your strength, build up your tolerance. And then even doing kind of unilateral work as well, because like you said, when it is kind of getting to that older age, and this applies to men as well, but, you know, falls and fractures, you know, aren't just, they're also due to kind of like clumsiness and not being able to kind of, you know, catch yourself if you stumble. So it also has a role not only in kind of, you know, building your bones, that if you do fall, that you've less likely risk of, you know, breaking them, but also you're less likely to just fall in general, which is key.
And we do see that like transition as someone ages, we see that transition away from those like faster muscle fibers to more slower muscle fibers. And that's not necessarily a bad thing. You know, like people go, oh my God, no, it's awful. But like, it's not necessarily a bad thing. However, it does come to the forefront if you're trying to catch yourself when you're falling. Even like, I mean, like using your legs, not even like, you know, using your arms or whatever. Like if you're just not able to move as fast, you know, if you're basically just not able to, you know, catch yourself in time, like even with your legs, and then even if you do catch yourself, you don't have the strength to support that or to actually, you know, whatever, like we're in a bad position then. And we can offset that to some degree. Like there's obviously, again, a natural decline with this stuff, but we can offset that to some degree by doing training. Like we can do specific training for older individuals, but we can also just train in general throughout our life, you know, to keep ourselves healthy and fit. Like this is the same stuff again. Like if you are a 28-year-old or whatever, and you're like, right, I'm just never resistance trained. You know, I've never done any exercise, and I've basically been sitting down for the last 10 years, very little stimulus on the muscles. Like you're still going to have some of the same issues that an older person is going to have. However, the older person has had way more years to accumulate those issues, you know, or they're at a stage where they've reached more frailty, I suppose you'd say the word is, where it's just they just can't catch themselves. They just have more of these issues present, you know. So yeah, we need to be doing some sort of training.
Definitely. So you're looking at kind of optimizing your bone health. You're looking at minimizing your strength loss. We're talking about the cardiovascular benefits, and as well, you know, pelvic floor exercises to protect the pelvic floor. So what I mentioned before about having that kind of that mixture of plyometric training and strength training. I mean, we also need to consider that plyometric training, you know, can completely set off kind of, you know, incontinence symptoms as well. So it's about kind of, you know, finding that balance, and as well deciding kind of which you kind of, you know, need first. Is, you know, is this something where you need to you know, talk to a pelvic health physio or kind of, you know, like a female health specialist, just so you're not kind of you're exacerbating prolapse, or that you're experiencing these incontinence symptoms while you're working out. So it's you know, finding a balance between them, and again, just completely based on the individual, kind of what your starting point is, or how you're going to kind of, you know, progress through your training.
And this is the hard thing for a lot of people, especially if you haven't trained before. It's very hard to know what you should be doing, what you shouldn't be doing, where you should be focusing your attention, all that kind of stuff. But also, even if you have trained before, like maybe you've been training your whole life and you think you've got a good grasp of training, you have to remember that the hormonal situation has changed now, and those hormones are responsible for, again, baseline function, you know. So you might be, oh yeah, I know how to train this way, I know how to do all this kind of stuff, and then you start coming across issues like incontinence or prolapse, different things like that. You're just like, well, I don't know how to train now. So it is one of those time periods, like we were talking about in the kind of post-pregnancy period. It's like things have changed now. we're going to have to come up with potentially new strategies, new ways to train, whatever it is, you know. And like we discussed as well in that, I think it was in that post-pregnancy one, postpartum episode, where it would be ideal if every woman could just go to a like pelvic floor specialist, or could just like, go to a well-qualified, you know, personal trainer, nutritionist, coach, like we just call them coaches, but like a nutritionist / personal trainer, and just go, yeah, cool. This is what we do. This is how you deal with the perimenopause and menopause stuff, right? Because we're talking about it here in this like overview, like, you know, fucking whatever, 20,000 feet in the air, like, these are the different things that you should maybe be aware of. But what you really need is that kind of specific advice. You really need that, okay, these are the issues that you're dealing with specifically. This is how we overcome this, or this is what we need to do to, you know, manage this, you know. And unfortunately, like, we can't give that in this episode. But, you know, we envisage a world where everyone had access to that stuff.
Definitely. It's knowing about who you can go to. I mean, your GP should be able to, you know, minimum refer you to, you know, a women's health specialist that can help with that kind of. So like pelvic floor exercise, those are kind of like your Kegels. You know, there's also a lot of like great apps out there. There's like kind of like a called Squeezy isn't one, you know, which is like an NHS.
Great brand
name. Great name. Which I think is like an NHS app. So there is a lot of resources out there, but even kind of, you know, having a look at those things beforehand and knowing, you know, kind of what are your symptoms yourself before you go to kind of one of these health professionals can be beneficial as well. But there is kind of help out there, but I think you do need to be assessed by a professional if you think you are, you know, particularly having symptoms of prolapse, you know.
So we'll get back to the pelvic floor now in a second, because I do want to touch on that. But just before we move on from the resistance training and, you know, cardiovascular training, Nicola, someone's coming to you. They're saying, I want to do something. I'm in the kind of perimenopause state, or maybe we'll do two examples here. Someone in perimenopause and then someone in the menopause, or like post-menopause, I suppose. They come to you and they're saying, look, I used to do a bit of training the last, you know, couple of years. I haven't done much. You know, maybe I went to a few classes in the gym, but I wasn't doing too much. And now they're thinking, I want to help my health. I want to make sure that I'm setting myself up correctly, right? So perimenopause, what are you thinking? How would you set up their training? Let's assume they have, you know, like most people, 3 to 4 days to train. What are we doing?
Yeah, it's funny you mentioned the class situation, someone who's done a lot of classes, because, you know, training is one of the things that's most beneficial for kind of women, you know, going through this period. But a lot of classes are geared towards, you know, aerobic training and Pilates, or, you know, kind of HIIT training, which actually isn't kind of, you know, what we want kind of women kind of in the perimenopause, postmenopausal to be doing. But in terms of training, what it'll look like for perimenopausal woman versus postmenopausal will be similar enough, to be honest. And it is just, you know, taking that person kind of where they're from, and kind of building up their strength from there. So you're looking at, you know, obviously kind of, you know, whole body resistance training, but particularly kind of looking at kind of ensuring kind of like unilateral movements, ensuring kind of posterior chain, and kind of building up kind of their back muscles as well, core, and just kind of ensuring kind of, you know, full kind of muscular kind of support, you know, for the body. But then up titrating kind of the amount of strength that we're using as well. So kind of bringing up the weights, kind of slowly titrating up over the weeks. But it is just kind of about, you know, assessing someone kind of where they are kind of at the minute, and then kind of taking them from there.
I actually think this is quite important. It's basically, we're doing a generalized program here.
Yeah, I know. Yeah, absolutely. The kind of main thing that you know, like I would change would be bringing in kind of more plyometric training. Like I said, it just has a different effect on our bones, on different parts of the bones that are kind of strengthened up, as opposed to kind of normally kind of loading through resistance training. So whereas I wouldn't have as much of an emphasis in someone, you know, my age, maybe I should, but I don't. But someone who's kind of coming into more kind of perimenopausal period, I'll put more of an emphasis on that, and do try to, now provided there's no kind of pelvic floor issues, that is something that I will be like, okay, no, we do need to kind of get kind of this more kind of higher kind of impact in. Again, we're not talking about box jumps up to like whatever level, you know, again, where the person's from, and slowly kind of bringing that up. But for post-menopause woman, it's the same thing. You're taking someone from where they are and just trying to get them better at that and get them stronger. You're still trying to load the joints. You're still trying to create muscle mass. I suppose the biggest thing is with perimenopause is that you kind of still have a bit of a capacity there to build muscle and to strengthen the bones, whereas that for postmenopausal woman, you're more so trying to kind of maintain. That's kind of the biggest thing, but you still have a greater need to kind of load the joints and improve muscular strength. Like we said, we don't have kind of estrogen there, we don't have its protective effect, and muscle protein synthesis, particularly postmenopausal, is a lot harder. We do need kind of, we'll be talking about nutrition, but we do need kind of higher protein boluses and enough stimulus from the resistance training to actually provide sufficient muscle protein synthesis to either, create muscle mass or at the minimum kind of maintain it.
Yeah. And again, it is one of those things where we have to be specific in terms of there are a lot of different things that we have to consider. Again, we could be talking about pelvic floor dysfunction. We could be talking about whatever issues that this person is having. But at the same time, we are still doing just a generalized resistance training program, whatever it is, 3 to 4 days, nothing excessive. Yeah, we might layer on some like plyometric work. And like you said, it doesn't have to be, extraordinary stuff. Like even stuff like skipping, people forget that like that is plyometric work,
Yeah,
like you could go, oh, I'm going to do 5 minutes of skipping as a warm up, which, you're learning a skill. You probably enjoyed skipping when you were younger. I know I actually really enjoy skipping, but it's one of those kind of fun things. And it is also teaching you a bit more coordination and everything. Now, I know everyone, especially if you haven't been in the gym in ages, you're like, fuck no, I'm not going to go skipping. I don't want people looking at me, whatever. But stuff like that, it doesn't have to be excessive. It doesn't have to be, like you said, like these depth jumps from fucking 12 feet in the air or whatever. It's just like, right, we want to do some sort of plyometrics, which is just like, we'll call it jumping and rebound training, because it's just obviously a lot of load bearing through the joints. But obviously, again, the caveat here is we need to be strong enough to support that stuff, right? So you might do a period of time where you're just focusing on resistance training, getting the body strong, preparing it so that you can bring in some more plyometric stuff, or maybe you're bringing in some very low level plyometric stuff at the start, but I do want to get it across that this isn't extraordinary. It's not. Yeah. It's not like a magical program, right? You're going to do 3 to 4 days in the gym. Like, yeah, okay, if you enjoy classes, you can still go to classes. We're not against classes. We're not against exercise in any form. But we're probably going to spend some more time just going, right, here are our major muscle groups. Here are the major, movement patterns. We'll say, let's make sure that we're at least loading them up and trying to progress that over time. Again, it doesn't have to be this huge bodybuilding program. It doesn't have to be whatever, but we do want to get stronger over time, or at least try. And we do want to make sure that we're going through at least the major muscle functions and targeting the major muscle groups,
It's one of those things, like we're still keeping a similar format to someone kind of in their 20s, but it's still, I suppose, you're not having as much of an emphasis on like tricep extensions or bicep curls, whatever it is. You are kind of looking, I hate saying the word kind of function, but you are kind of looking at things like strengthening the back. Or I had an old client with multiple myeloma, lady in her 70s. So one of the things for her was, like we were mentioning, the stairs, kind of like weighted step ups, like there is kind of like great carryover with a lot of these movements. Again, we're getting kind of like unilateral in, getting something that she's going to need, particularly as that kind of, so multiple myeloma eventually progresses, so the bones of it is the same, but there are some kind of smaller differences that you'd be putting more an emphasis on. Like I said, you're not focusing as heavily on chest and triceps.
Yeah, I'd get that isolation.
Maybe you should. But
do you want to see that granny with fucking jacked 18-inch arms?
Yeah.
Well, anyway, right. So one of the things that does potentially change our general recommendations is stuff around the pelvic floor. We might bring in some more pelvic floor specific exercises, but like you mentioned a few times, we might also be thinking, okay, I'm going to be getting you to do, again, like even skipping or something, or resistance training. Maybe I'm getting you to do some deadlifts or whatever. we might have some incontinence, we might have a risk of prolapse, we might have stuff around this, like the pelvic floor, dysfunction, or whatever you want to call it. So how does that change things? Obviously, we have to be aware of it. That's the first thing, you know, but how does it change things in terms of, are we just adding in a few different exercises? What's the story here? The pelvic floor, training, perimenopause, menopause.
Yeah, so the way that we're changing things is that, if you know, if you are suffering with, you know, particularly stress incontinence, that's what you'll experience if you're doing you know, skipping, or, you know, box jumps, you know, squat jumps, whatever it is. And not even that, when we'll still experience it with things like heavy deadlifts and heavy squats, you know, etc. And again, that's just kind of when you just can't kind of, you know, hold your urine in, you know, essentially. So
you do see this, we've said it before, but you see this all the time. Well, not all the time, but you see it like in a CrossFit gym, or people that do like powerlifting or something like that. And, you know, they're basically, I don't know, like sumo deadlifts is always one that you see people do it on, because it's a bit more visual and stuff, but people will basically like pee themselves, you know? So that happens.
Yeah, exactly. It's some, and it's quite common. But you know, it's not necessarily, you know, normal. You know, we should be able to kind of, you know, be able to kind of, you know, control that. But you know, if kind of that is your issue, it is you know, kind of taking a step back from that training kind of for now, and kind of staying with kind of lower impact training that isn't causing the incontinence, while concurrently working on your pelvic floor. And working on those exercises, like we said, you know, whether you're doing Kegels, you know, whether you've already kind of, you know, sought help from a professional, and whether you're trying out an app first, and seeing kind of what works for you. But it is something that I would link in with your GP kind of, you know, minimum about, because it's not something that you have to kind of suffer through. And especially if that's going to be like a barrier to exercise for you, it is something that there is help there for, and should be used. Like you said, there's, you know, pelvic health physios, there's, you know, specialists, women's health specialists, there's GPs that have like special interests in this kind of stuff. A lot of, you know, general GPs, I mean, this is what they're seeing the whole time anyway, even if they're not a specialist in the area. And if not, they can refer out, or kind of minimum, I mean, you know, downloading some of these apps, like I said, they're fantastic, and they can kind of really guide you through a lot of these exercises.
And like you said there, it might be a case
slowly coming back into training, you know, slowly again, like we were saying, you know, these kind of like deficit box jumps, maybe trying a smaller one and seeing how it goes.
Yeah, and that's the thing. It's not an either or stuff, right? If you go to the gym and you're like, oh, I actually really feel I can go back to piss myself here, you know, like that can be very off-putting, naturally enough, right? But it doesn't mean that you have to just completely forego resistance training. Like there are going to be exercises that you can do, and it's just not an issue, right? So we can still be focusing on those. We can still be, you know, progressing those. There might be a few exercises that you're like, right, these ones seem to be really like problematic for me. We might have to dial back the intensity of those. Like again, obviously it's not like this like pelvic floor dysfunction, incontinence, whatever is like one thing. Like it's different for everyone, right? So we might just have to dial back the intensity. Okay, you can't do this like really strong Valsalva maneuver. That's what seems to really set it off for you. So we're going to just, rather than having this as like an RPE 10, you know, we're going to go, okay, let's just dial it back. It's going to be 5 or 6. We're still going to get the movement in. We're still going to train it. That seems to be okay for you. Whereas for someone else, it might be a case of, look, if we even get down reach down for the barbell there, you're going to feel like you need to piss yourself, right? So again, it's going to be different for everyone. So don't just take it as like, oh yeah, I have a little bit of incontinence, so I'm just not going to go to the gym. I'm not going to focus on that until I get the incontinence completely sorted, because you're kind of missing an opportunity there, right? However, and this is especially true for personal trainers, if you are training someone that is in this perimenopause, menopause period, like it is something to be aware of. It is something that you might start thinking, okay, well, how am I going to structure the resistance training session that I have planned for this individual, so that first of all, maybe they're nearer a bathroom. It's not something that's like we're 4 floors deep and there's no bathroom here, you know, different gyms, different setups, whatever. Or we're just going, okay, they might have an issue with these exercises, so I'm going to make sure that I'm communicating with them, just asking them like about this stuff, not just assuming that, oh, it's all good, and then modifying from there, you know. And then on top of that, especially on an individual level, but if you are a coach, if you really do care about your, clients' health, fitness, all that kind of stuff, like there are pelvic floor exercises that we can do.
Yeah.
Some of the stuff, it's like, right, it depends on the issue. Ideally, we would just go to a pelvic floor specialist, and ideally, if you are a personal trainer and you're coaching a lot of women you're coaching a lot of women, full stop, like ideally you would do some sort of pelvic floor continuing education just so you're really aware of that stuff. But that is something that we could maybe bring in. Like I've done that with a few of my clients that just have had issues. We're like, right, in consultation with their GP or again, their pelvic floor specialist, we're going to bring in some exercises, and we might do that as part of, we'll call it the warm up. It's just like, right, this is when we do them. We're freshest. We're really going to focus on them. And then maybe we might do them at the end. It depends on the exact issue, because it might actually be wrong to do them at the end. But again, it depends on the exact issue that's going on. But also there's stuff that I'm going to give my client homework. It's like, right, this is stuff that I want you. You're sitting at your desk all day. It's like, you can be doing some of these exercises. It's like set a reminder on your phone, do whatever needs to be done, So there is a little bit more that we can do with the pelvic floor exercises, but I think the real key here is just being aware of it for one, but then also just not closing yourself off to exercise if you are dealing with some sort of pelvic floor dysfunction.
Definitely. And like you said, it is worth talking to your personal trainer about, I don't think in my PT course there's anything really mentioned about pelvic health, which is unfortunate. But, a lot of personal trainers, again, are upskilling and will have a little bit of knowledge in that. So if you do have, a comfortable relationship with them, it is worth asking, because, minimum they can look into it for you, and kind of between yourselves kind of, put a plan in place.
100%. So on the training, the exercise front, is there anything else that you would like to make a note of? Because look, we do realize that it's not like we gave you the program. We're not like, do this program, this is the one that's going to fix everything. Basically, on the training front, at least in my estimation, we just want to keep training. We want to do like 3 to 4 resistance training sessions per week. 2, I would be happy with 2 if we could get those in. But ideally, we're getting in that kind of 3 to 4 range. We're doing some cardiovascular exercise as well. And then maybe we're starting to bring in some more plyometric stuff. Doesn't have to be excessive, but just for, potential bone benefits there. And also there are potential benefits in terms of being able to catch yourself and, whatever, just function, we'll call it, but nothing excessive. On the training front, not much changes, right? Overall in the grand scheme of things, right?
Still focusing on strength, and then there's just kind of not even minor details, but other things that you're putting more of an emphasis on than someone maybe in their 20s, but there's no huge overhaul training.
So what I think we do is we'll kind of wrap it up here, and in the next episode we'll talk about nutrition, because there are a few different things that we would actually do with the nutrition side of things, and in that episode we might also get onto like hormone replacement therapy and stuff like that, because I know we've mentioned it a few times during this episode, and it is something that, again, you need to be aware of, because like you said, like your doctor might just be like, right, you're going perimenopause, hormone replacement therapy. And that, again, a lot of people are hesitant to that. Some of that's true, they've heard whispers of different things, or maybe it's a lack of knowledge. They're just like, I'm not a pill popper, like you said. So hopefully we can clear up some of those issues. But do you have anything else that you want to make a note of?
No, all good.
Fantastic. So other than that, guys, you know where to find us. I'm not going to repeat it every single time. That's Gary's job. But you can look at all the info wherever it is, above, below, wherever it is that you listen to this stuff. You can find the links to all of the stuff that we do. Follow us on Instagram. That's where we put out a lot of content, a lot of actionable information in terms of, this is what you would do. Here's a helpful tip. That's the goal of our Instagram, the goal of our social media. Obviously, look, we're a business. It's marketing as well. There's, I'm not going to be dishonest here and say, it's completely altruistic. It is marketing, right? But ideally, you would get some benefit from that. Ideally, you would come away from following our Instagram page, following our social media, and going, I'm actually learning stuff here. I'm actually getting actionable, helpful advice. Again, I'm not going to be dishonest and say there's no ulterior motive as well, but the goal of our social media is to provide actionable, informative, helpful advice. So that's what you should get when you go there, right? So Instagram, that's the best place to follow us. You can, of course, follow us on the email list. We do send out emails every single week. So if you enjoy that stuff and you just want to read an article or a piece of content, a bit of information about whatever, or, you know, get the insider scoop of what's going on at Triage or whatever, email list, that's the place to be. Obviously you can follow all of us on social media. That's pretty cool as well. But the final thing I want to say is we do have coaching spaces available. I know, Nicola, you have a few coaching spaces available. So if people are dealing with, you know, female specific issues and they just want some help, like, they can get coaching from you. But I know you also do consultations. If people are like, right, I don't necessarily need, you know, full coaching, but I have these different issues going on, like, we can organize a consultation with you as well, you know. So there are services available to you if you're a listener. You can go to our website. Again, the links are all below, so you can just peruse them, find the one that you want to click and click it. But other than that, guys, look, I have nothing else to say. We'll talk to you in the next one, and we'll see you then.